I got an instruction that it is being recorded.
Yes,
Okay,
sir. Yeah,
I have
please.
no problem.
Yeah.
In bone remodeling, that happens in all weight-bearing skeleton. That means that doesn't happen in the skull or in the facial-maxillary bone. It will happen in the weight-bearing. That means the lumbar spine through which the center of gravity passes, and the appendicular. That means the tibia, femur, and our hand bones, which are involved in various weight-bearing activities. There, this bone, and those are the sites where osteoporosis happens. And that osteoporosis are of different categories. I'm not going into the details of those things. But the common theme about osteoporosis is that the bone remodeling gets affected. Now, what is this bone remodeling? It is composed of a cyclical event consisting of resorption, reversal, and formation. The one this is shown here. Also, there is a quiescent phase, that is when no remodeling is happening on bone surface. So this is a quiescent surface that suppose required to undergo remodeling. That means first the existing bone and matrix would be removed by the bone resolving osteoclasts. These are giant multinuclear cells. They differentiate from hematopoietic stem cells. They have more resemblance with macrophages, but they are multinuclear, and they resolve a pit on this quiescent surface requiring remodeling, and it generally takes 3 to 4 weeks to happen in human. And then there is a reversal phase about which not much known, but at least what happens is that the pit gets populated with osteoprogenitor cells. That means the osteoblast precursor cells populate that resorbed pit, and it takes close to 1 week. And then the longest portion of this remodeling cycle occurs, which can happen between 3 to 12 months, depending upon how voluminous the pit has been made. And so this is the longest phase, formation. Now, what you notice that in normal adult, after the adult has achieved peak bone mass, the amount of bone that has been lost by resorption is not completely filled up. So there is a deficit that happens in the normal adult condition. So over time, even in the normal circumstance, the bone mineral density would be reduced, which is an aging phenomenon. And in osteoporosis, it is remarkably reduced. The formation part is remarkably reduced. So the deficit is much bigger. And generally, when anabolic therapies are given, for example, PTH 1 to 34 or PTHR, P1 to 36, that means teriparatide or abaloparatide, or more recently romosozumab, which is a sclerostin monoclonal antibody, those treatments will fill the pit more than what was there. So that is called the anabolic therapy. And we are interested mostly on this anabolic segment. What are the molecular targets and what are the small molecule drugs that can give rise to anabolic response. So we have this large repertoire of preclinical models. Ovarectomy-induced osteopenia in all 3 rodents, that is the most frequently used animal models for studying postmenopausal osteoporosis. Besides, we have glucocorticoid-induced osteopenia. This is something that happens very commonly to people who are in need of long duration glucocorticoid, or people commonly say it is steroid. So these are glucocorticoid that causes osteopenia. Then we have femur osteotomy model to study bone regeneration in both rat and mouse. Then we have rat model of osteonecrosis. We have recently established rat model of chronic kidney disease induced mineral bone disease. We have rabbit and rat model of critical size defects, rat model of osteoarthritis, rheumatoid arthritis, and we also have obesity induced bone loss model in mouse. So this is a large number of animal models which we have. Now, our country, our center is actually, according to these three articles, research articles, starting from 2013 all the way up to 2020, consistently the CDRI scientists, ASTHI investigators, are the most productive and highly cited authors in osteoporosis and bone health. So to give a flavor of what our achievement is, that since 2011, 191 papers have been published from 17 investigators, ASTHI investigators, having an average impact factor of 4.9 and H index of 31. We also have non-strategic collaboration with industry, in which we do industry-sponsored research. We have done so using this microcity, where microcity has been used. The both type, 2072 and 1276, both have been used. We have done industry-sponsored project with Glaxos GSK, Tata Chemicals, Eurofin Advenus. We so far have academic collaboration of almost 35 investigators, but more recently, these are the most frequent collaborators from AIMS New Delhi, NDRI Karnal, IIT Bombay, IIT Roorkee, SGPGI, Lucknow, and Jamia Hamdard University. They are more recently doing collaborative research with us. But mind you that I'll remind you that we so far have, this microcity has been used by close to 35 investigators all over the country. Now, I will give some example of where microcity has been used in our various animal models that would help you in understanding what kind of collaboration that can be established with CDRI, with our ASTHI Center. So this is I'm just showing an example of effect of an investigative drug, and this is the compound on fracture healing. In this case, a rat femur osteotomy model was developed. It is basically through diaphysis, a 0.8 millimeter drill is made through the diaphysis, and the treatment starts next day and is given for 12 to 14 days. And then we do the microcity scan to see, this is the callus that has been formed, and with the drug treatment, we measure bone volume by tissue volume to get an idea of the bone regeneration that has happened in response to the drug. In this case, you can see that in normal animals, there is significant increase in BVTB in response to this drug, and also in overectomized osteopenic animals. In both cases, this GTDF has increased bone regeneration at the fracture site or the drill hole site. Now, this is an example of rabbit critical size defect, which we also create in our center. And here we used a biologics, a peptide, investigative peptide. What we do with rabbit critical size defect is that we take the tibia near the dorsomedial region. We create a critical size, that means 15 millimeter high, 3 millimeter wide, and 2 millimeter deep wound that is then taken out, and then we put hydroxyapatite gelatin scaffold, and then we suture the wound, and then we start giving the treatments. In this case, lactoferrin derived peptide, small peptide, was used as a treatment. And after 45 days, when we sacrifice the animals and did the scan, so the vehicle group had this volume of bone regenerated at this site versus this is the response to LP2. So BVTV was significantly increased with LP2 treatment. We also, this is unpublished, but to show you that one could also, if you don't have a rabbit facility, you can do it in rat, adult rat in the calvaria. 0.8 millimeter drill hole can be made on the calvarium, and then the treatment can be given for 2 weeks. And in that, the good part is that you can do the live animal scanning. Here exactly that was happened after live animal scanning. We saw that one bone cement containing hydrogel had significantly filled up the the drill hole. That means showing that a strong bone regeneration response was obtained. Now, those were about the fracture, critical size defect, and all those issues related to bone regeneration by in response to treatment. Now, I will give example of postmenopausal osteoporosis model, in which the animals undergo bilateral ovarectomy, and then we study the long bones and vertebra, means femur, tibia, and vertebra. Here I'm giving example from a rabbit study which we did with an investigative drug, actually more towards therapeutic repurposing. This is a phosphodiesterase inhibitor, pentoxifylline. This is pentoxifylline and PTX, and was compared with PTH, or rather teriparatide. I would say it was not full-length PTH, it is 1 to 34 PTH teriparatide. Pentoxifylline is given oral, and PTH is, as you know, that systemic. And after this, what we do is that we make the rabbit osteopenic first. That means we overectomize them, leave them for 3 months, and then we start the treatment. And in this case, the treatment was given for 4 months. And then at the end of the treatment, this is an example of fifth lumbar vertebrae, and BMD, BMC, and bone volume all were significantly reduced in the overectomized animal given vehicle, and pentoxifylline and teriparatide both completely reversed this osteopenia to the level of the estrogen replete animal, that means the ovary intact animal, which suggested that the anabolic response was of pentoxifylline was comparable to PTH. This is an example of from our study from osteopenic mice, and the data I'm showing is from the femur trabecular region, the femur metaphysis region. And here we used PD, phosphodiesterase 5 inhibitors, sildenafil and vardenafil. And here also we found that in the vehicle treated osteopenic group, there was a strong erosion of trabecular bone, as evident from low BMD and BVTV. Remember, in the microcity, we get volumetric BMD as opposed to DEXA scan where you get aerial BMD. Here we get volumetric BMD. And with the treatment of sildenafil, vardenafil, and PTH, there was complete recovery of the trabecular bone. So you have seen 2 examples from osteopenic animals where osteopenia was induced by overectomy. Now I will give you an example of secondary osteoporosis or drug-induced osteoporosis. So first I will show you an example of a drug-induced osteoporosis. This is the most prevalent form of osteoporosis because it can happen at any age, any individual requiring long duration steroid treatment. Long duration, by the long duration I mean any time above 3 months. Steroid treatment or corticosteroid treatment can develop osteoporosis, and unlike postmenopausal osteoporosis, here the bone loss can happen at any site. So here with the methylprednisone, we induced osteoporosis in rats. So this is an example of femur metaphysis region compared to vehicle. You can see there is significant loss, and this is fifth lumbar vertebrae. Also, you see erosion of trabecular region with methylprednisone, and then we used here a phytochemical standardized standardized extract from plant is called from Cassia occidentalis, and we made a formulation. And what we found here when we quantified this data, microCT data, what we found here was that with methylprednisone, you have significant loss of BMD and BVTV at both femur and vertebra. And this formulation, phyto extract formulation, have significantly reversed this osteopenia. This we have recently developed. It is a very challenging model. It is CKD, that means chronic kidney disease induced mineral bone disease. And the reason why we developed is that nearly 1.7% of human globally suffer from CKD. That means 17 every 1,000. That is a very high number. And it proceeds, it progresses, or it deteriorates quite rapidly. And then there could be secondary osteoporosis caused by hyperparathyroidism. And so here what we have done is that we have created a 5/6 nephrectomy. That means here one full kidney is removed and 1/3 of the other kidney is kept. So that is 5/6 nephrectomy. So the animal has now 1/6 of the renal mass to function. In this 5/6 nephrectomy, we don't really see any cortical porosity. But then if they are given high phosphate diet, then hyperparathyroidism sets in with 1.2% high phosphate diet, HPD, high phosphate diet, you start to see cortical porosity. And when you give them 1.8% phosphate, then you have a tremendous porosity through the cortical region, both in femur as well as in tibia. You can see tremendous cortical porosity happening. This we have established. We are planning to test some drug on it, and it is not published yet. So that is what I told you about the postmenopausal osteoporosis, and one example each from secondary osteoporosis and drug-induced osteoporosis. Now I would move on to a bone loss condition happening due to inflammation. You know, arthritis, particularly the rheumatoid arthritis, it is an inflammatory, it is an autoimmune disease, rheumatoid arthritis caused by the antigen from bone protein, the most prevalent of them being type 2 collagen. So what we do is that we take mouse, particularly we don't take any mice, we take DBA1J mice. They are actually very poor breeders. So to get the colony, you have to work hard to have adequate number of animals to do the study. So we had that number, and there what we do is that in DBA-J1 mice, we give type 2 collagen in Freund's adjuvant. And then by 42 days, you start to get full-blown arthritis and also subchondral bone loss. And that is what we did here in the tibial region in the CIA. You see a remarkable bone loss happening in the arthritic animal, evident from low BMD and low BVTV. And here what we used a peptide from Fasciola helminth, helminth that is widely prevalent in Indian population. And generally those helminth have a defense mechanism by which they suppress host immunity so that they survive. So they produce the protein. From that protein, we we designed a peptide and found that that peptide very strongly inhibit the autoimmune reaction, and by doing that it inhibited the bone loss, means the tibial subchondral loss was mitigated significantly. Then we have a model called osteoarthritis. It can be created chemically as well as surgically. Remember, chemical creation of models are more challenging because of problem with reproducibility. This is surgical, which is anterior cruciate ligament transection. So that we do it in the rat, and as a result, you see that here the region gets the shiny nature of the tibial bone is gone. The tibial plateau was gone. And with the treatment, this is Spinecia oleracea extract, standardized extract treatment given orally. And you see the recovery of the shiny region, or the recovery of the bone region that was eroded. I'll give you an example here. If you see the radiograph, this you see this region, this gap is extended between femur and tibia. This gap extension is caused by ACLT, and when the treatments were given, this gap were recovered or was found to be less than the ACLT control. And when we measured this tibial subchondral bone by microcity, we found that the VVTV was significantly decreased in ACLT, and some recovery, significant recovery happened with this Spinecia oleracea extract at two different doses of 125 and 250 milligram per kg. Another very common inflammatory disease is inflammatory bowel disease, and that is very common in India and world over. And here we have created an animal model. It is also quite recent one. I just give you an example. So TNBS is basically 2,4,6 trinitrobenzene sulfonic acid. This is a hapten based antigenic stimulus that causes excessive cell-based immune response, and that leads to acute Th1 inflammation and infiltration of CD4 T cells that produce various pro-inflammatory cytokines. Now TNBS shows mucosal lesion. So this is vehicle, and you can see the mucosal lesion that resembles Crohn's disease in the colonic epithelial, in the colon. So that is how the IBD model was created. So TNBS is given transrectal, and after 1 month, when we studied the femur metaphysis, we see significant loss of trabecular bone. So you got the flavor of inflammatory bone disease model and bone loss. Now I will give you an example of how we create osteonecrosis. Creating osteonecrosis is a very challenging phenomenon if you have to do it by corticosteroid, and that is done very commonly. But it is very difficult to reproduce, and there is a large amount of corticosteroid is given that there is tremendous mortality. So we actually found a new use of an anti-leprosy drug called clofazimine. And this clofazimine causes osteonecrosis. How? It switches the bone marrow resident MSCs, mesenchymal stem cells, into adipocyte. So the entire bone marrow is filled with adipocytes. So this, what we do is that, and this is again, microcity has helped a lot. So these animals, after the end of the treatment, the femur bones are decalcified, and then they are treated with 2% osmium tetroxide and 5% potassium dichromate for 72 hours. And then they're washed, and then we do the microcity to measure adipose volume by tissue volume. So you see, this is a control animals. The entire diaphysis region was devoid of marrow, but you see here, even the growth plate is filled with marrow in this case with clofazimine. And so the adipose volume by tissue volume was significantly enhanced. And you see the typical instances of osteonecrosis is that empty cannulae. Can you see this empty cannulae without nuclei? So that is a hallmark of osteonecrosis that has happened because of clofazimine. And then the last example I will give is the effect of phytochemical in a cafeteria diet induced bone loss. So we use two models. One is atherogenic diet and another is high fat diet. Generally in atherogenic diet, it contains around 15 to 16% fat, some 1.25% cholesterol and 0.5% sodium cholate is used. And in case of high fat diet, 40% fat calorie comes from fat. 40% fat is included compared to 3% in normal chow diet. And when the mice were treated like this for a month, you see the tremendous loss of trabecular bone in the femur of atherogenic diet receiving animals and both high fat diet receiving animals. And then one novel compound, the cavionin glucoside compound from Dalbergia tissue, significantly recovered bone at the femur side, not up to the mark of the control diet, but compared to atherogenic or high fat diet. This we are trying to establish in continuation to the high fat diet situation is that to measure the distribution of visceral fat in mouse so that we correlate the visceral fat with the bone loss, that kind of situation, because visceral fat is an indicator of insulin resistance and this high fat diet also suffers from insulin resistance. So that way we are trying to correlate, and in our attempt we are trying to first measure very clearly the distribution of visceral fat in mouse.
Yeah, just oops, better.
Okay. Yeah, please go ahead. My time is up, right? So I'm in the summary slide.
No, sir, you can just go ahead. No problem. It's somebody is not muted, so I just put it.
Okay, so and this is another latest attempt we are making is to study in vivo vasculature through microCT, and in this case we injected the animals with barium sulfate with, I think it was close to quite a high amount of barium sulfate. I don't remember how much, so close to 50% barium sulfate was given, and then the animals are fixed with formaldehyde, and then the organs are then scanned with microCT. Our aim is to study vasculature finally in decalcified bone, and this is one example of seeing in vivo vasculature in liver. So I have tried to give you examples from our 9 preclinical models using various parameters, using microCT, studying various parameters. So in summary, I can say that microCT is the backbone of our bone research, that means ASTHI research. So more than 60 PhD theses has been successfully defended where microCT was a integral part from both CDRI and non-CDRI PhD students. More than 200 papers were published where data from microCT have been used from both CDRI and non-CDRI places, as well as several industry-sponsored projects has been used using this microCT. Thank you.
Thank you very much, Dr. Naibedya. It was a wonderful.
Any clarification, any question, I'll be very happy to answer.
Sure. Yes, Shiva, please go ahead.
So Dr. Naibedya, it's a very interesting presentation. So
It's kind of frozen. It might be sort of stop start.
And
I have one very interesting details about the adipogenesis in the from bone marrow adipogenesis. It sounds very likes to be kind of a new approach looking into that. I'm just curious to know that are you look into the vascularations around the bone, because that could, when you do the surgery, it may damage the vascularations also, which may lead to delay in the recovery of the animal. Is this something interesting uh, to work on the vascularization also for your research areas?
Yeah, vasculature we have studied, as I showed you in the last slide, that we are trying to quantify it using microcity. On the other hand, one can do it, and which we have done and also published. We have done it using a whole body imaging system where fluorescent microspheres can be injected through tail vein, and then it gets distributed to bind with capillary beds, and using that in vivo imaging system, we can measure vasculature in bone. That we have done, but the reason why I haven't shown that data is because that was done not using microcity. But yes, we study the vasculature aspect as well, in bone vasculature aspect as well.
Sure.
so any participants has any questions for Dr. Naibedya? Okay.
Let me also announce, take this opportunity, is that for all academic institutions, microcity is usable for free. All you have to do is to book your slot. Generally, you have to plan it well ahead of time because there's a long queue in the slot. But for all academic institutions, it is used for free. It can be used for free. Okay.
Okay. Thanks, Dr. Naibedya. Once again, I would like to thank you very much for your time on the talk.
Okay. Thank you so much.